Hi everyone, I have the honor of introducing Dr. Alik Farber. Dr. Farber is a graduate of Brown University and obtained his medical degree from Harvard Medical School. He completed a residency in general surgery at Massachusetts General Hospital, a vascular surgery fellowship at Dartmouth-Hitchcock Medical Center, and an endovascular surgery fellowship at the Southern Illinois School of Medicine. In addition to his role as Division Chief of Vascular and Endovascular Surgery at Boston Medical Center, Dr. Farber is also Medical Director of BMC's Catheterization and Angiography Laboratories and Co-Director of BMC's Vascular Non-Invasive Laboratory, as well as Associate Chair for Clinical Operations in the Department of Surgery. He is a fellow in the American College of Surgeons and is a member of the American Board of Surgery. He is a member of many national and regional medical and surgical societies, including the Society of Vascular Surgery, where he was elected to Distinguished Fellow status in 2013, the Society of University Surgeons, the Western Vascular Surgery Society, the New England Society for Vascular Surgery, the International Society for Endovascular Surgery, and the Society for Clinical Vascular Surgery. Dr. Farber has served as principal investigator in a number of clinical trials and is currently a national co-chair of the BEST-CLI trial, a $25 million grant awarded by the National Institute of Health, which we will be discussing today. He has written and published many articles about vascular and endovascular surgery, has served as a moderator for various vascular meetings, and has developed a formal education program in vascular surgery while at Cedars-Sinai Medical Center in Los Angeles, California, which resulted in the Golden Apple Teaching Award for teaching and mentoring residents. Since his arrival at BMC, Dr. Farber has made it his goal and mission to foster continued clinical excellence and academic productivity.
Just to get started, we're going to just start with a general introduction to critical limb ischemia. And it's basically a state of arterial insufficiency manifested by inadequate tissue perfusion at rest. For Americans older than 40 years old, the annual incidence is about 0.4% and the prevalence of 2.4%. And the rate of survival of CLI at 4 years was 46%, and only 42% were alive and free from major amputation. So this condition does have a lot of morbidity and mortality in the patient population it affects. So that is why we are trying to come up with the best treatments possible to save as much of the lower limb as possible in these patients. So when doctors are diagnosing patients with critical limb ischemia, they do have certain criteria systems for it. One common classification system that they use is known as the Rutherford classification of CLI. So the classes are broken up from 0 to 6, and going from completely asymptomatic to major tissue loss and full-on gangrene crawling up the foot. The BEST-CLI trial focuses on Rutherford classifications 4, 5, and 6, which 4 is known as ischemic rest pain. 5 and 6 both involve tissue loss. We put a picture of what a 5 would be, which has minor tissue loss like a non-healing ulcer, focal gangrene, and below that is a picture of major tissue loss, which would be a class 6, which is gangrene extending above the transmetatarsal level, and the functional foot is no longer salvageable at that point. So the BEST-CLI trial also has its own definition of CLI, and within its target population, they're still counting it as arterial insufficiency with gangrene, non-healing ulcers, rest pain, and it's corroborated by at least one of the following hemodynamic criteria. They are focusing on Rutherford classification 4 and 5 and 6, and within that, they're including measurements of the ankle systolic pressure, transcutaneous pulse ox, and a flat tarsal pulse volume reading, as well as a toe measure. And they have to meet certain hemodynamic characteristics into the research group.
Terrible trial, which really isn't recent trial, which was from years 2000 to 2005, only consisted of 452 patients in the UK. And so in theory, it was very similar in nature, but the BEST-CLI trial goes into a much more expansive nature and into, as we'll soon discover, as we'll soon cover, a much more advanced way. It includes much more different component of methodology, but we'll get into that. So basically, the basal trial is a very similar or comparable trial with a more older variation. So as you can see, the outcomes were based on either balloon angioplasty or bypass surgery for severe limb ischemia. And the trial essentially found very comparable outcomes in terms of amputation-free survival. And so this is where we get into the BEST-CLI trial overview. And so this is a landmark trial because it's the first randomized controlled trial comparing endovascular to open surgery bypass. They also included a very important one, which is a more practical component, which we'll get into later, which is the hybrid, right? And that's basically an endovascular / surgical, fusion. So this is in North America, and it is a prospective, randomized, multidisciplinary trial. And so the basic idea, the thing that you have to take away from this is that it compares treatment efficacy, functional outcomes, and quality of life, as well as cost. It's 140 clinical sites, and it began its enrolling patients in August of 2014. So as I previously alluded to, there are three treatment options, essentially through a coin flip, and we'll get into the specifics of it. But the three, as we stated, was the open surgical bypass, and the literature supports that there are complications to this procedure, but it does have excellent limb salvage rates, which is a lot of its claim to fame for the vascular surgical community. The endovascular stent placement, which demonstrates an associated decrease in perioperative morbidity and mortality, and a hybrid, right, including essentially a mix of both. And so this is a very interesting way that they essentially came to this. So the methods of this, so they essentially had 2,100 patients, both open and endovascular. And so what they did was they found the patients, they vein mapped them, they did angiography, and found out if they were eligible. Now, a very interesting component to this was the fact that a lot of these patients, some of them, because of their level of claudication, their level of limb ischemia, weren't viable to have the saphenous vein used. And so that was a problem. And I like the way that they, just objectively, it was very interesting to see the way that they found a spin to this. So they found an alternative conduit vein as an alternate for the patients who were still eligible for this trial. Essentially, to not use the saphenous vein, they used a brachial vein. And so through that methodology, we're essentially here with the trial, they were able to allow all of the patients to maximize randomization. They were able to use this to allow the patients, all patients, to be eligible for either endovascular or surgery. And so that brings us down here, which is why you'll see that based on a coin flip, which is the randomization, you'll see that the numbers of the alternate conduit, which is 480 over here, essentially broke even, right? Almost exactly to the T, right? Half of 480 is 240. And so these patients were eligible, for the treatment. And so they broke them down and they followed them up in a 1 month post-procedure, 3, 6, 12, 18, and 24 months. So it was a very interesting workaround to a very prevalent problem. Okay, so the first thing that they were looking for was the male-free survival, which is major adverse effects. And as you can see, The main thing that they're looking for in terms of outcome is the essentially above ankle amputations and major reinterventions, as well as a secondary efficacy endpoint, which is the amputation-free survival and need for reintervention. So essentially, we're looking at the success rate at a macroscopic level. And so just to summarize what we've gathered from this, the BEST-CLI is the first randomized controlled trial comparing the endovascular therapy to the open surgical bypass in North America. And the aim was the treatment efficacy, functional outcomes, quality of life, and cost of patients. So these are our acknowledgements. Thank you, Dr. Farber, for being here, the opportunity to learn this. Thank you, Dr. V, for providing the mentorship and feedback, and all the students who helped make this event. And so we'll move on to a question and answer session.
I can go ahead and start us off. First of all, congratulations, Dr. Farber, for designing and kind of carrying out such a huge, important study. My question kind of comes from like the logistical aspect. This is a massive study with like 140 clinical sites enrolled at one point. And so there's like hundreds of people working on this. I was wondering from your perspective, like what have you kind of learned is necessary to kind of coordinate and carry out successfully a study of this magnitude and size?
Well, thank you, Matt, for the question. I think before I answer that particular question, though, I want to give some perspective about how this trial came to be, because I think it's a really good story. Everybody can hear me okay? Okay. So it was astounding to me when I finished my training and started practice that the decision to whether or not to offer endovascular therapy as a strategy for CLI or to offer a bypass seemed to be really not based on a lot of science. It was obvious to me, I spent 5 years in private practice at Cedars-Sinai, and it was sort of obvious to me that, if there, for instance, I was part of a vascular surgery group and we did a lot of bypass surgery, and the radiologists there did a lot of endovascular procedures, and there was a lot of, the same patient might be offered this or that. And when I came to Boston, it was furthermore delineated in the practice that I observed at Boston Medical Center. And so a friend of mine, Matt Menard, who is he's a vascular surgeon at the Brigham Women's Hospital. I've known him since medical school, and we also trained together in general surgery. We basically met at a conference of the New England Society for Vascular Surgery in 2007 over a beer. We were sort of drinking beer and sort of after some lectures, and we started talking about how crazy it is that there's so much equipoise in how we choose to treat our patients, that sometimes that decision is based on the availability of an operating room or our personal schedules, and that it was kind of crazy that was the case. And when we thought it might be interesting to really answer the question about what strategy works best. And we, of course, knew that there was only one trial, the BASIL trial, that was ran by Andrew Bradbury, who at that time we didn't know, that they tried to answer that question. But that trial was criticized a lot for many reasons, not the least of which the only endovascular procedure that they allowed was angioplasty, which was obviously made it obsolete almost immediately and certainly not relevant in anywhere outside of England. And so we knew that there wasn't a lot of data, and that's how it started. And we sort of queried a number of people. We sent a survey out, and in fact, many people agreed that their decision to kind of choose this or that was endovascular or surgery was really not based on science. And we ended up submitting a grant, and that's I can probably spend an hour or maybe two talking about that in itself. So anyway, that's sort of the background. You're right, Matthew, that the trial of this magnitude, we actually activated 174 sites, In the end, we had 134 at our maximum, because what happens is that you activate sites and some sites get closed and some sites, for whatever reason. So it's sort of it's a dynamic process. But when you have all these sites and all these investigators, and the trial is multidisciplinary, so we actually had to, even though it was conceived by two vascular surgeons, we obviously felt that we had to involve everybody who treated CLI, so radiologists, cardiologists, vascular medicine specialists. And so we've created tried to create an environment across the country that allowed people to work together. And as you can imagine, there was in some places there was conflict to that end. And so managing these sites, managing the various, we had specialty PIs. So every site had specialty PIs. So at a site, so for instance, the Boston Medical Center, at the time we had cardiologists, radiologists, and vascular surgeons all doing procedures for CLI. And so we had 3 specialty PIs. And getting these people together and getting them to discuss the trial and to enroll somebody, 2 individuals, one who was credentialed in endovascular and one who was credentialed in surgery, had to agree that the patient was the right fit for the trial. So you can imagine the complexity and managing these people and then ensuring that they enroll, because they might open up their site and then they're not enrolling, and meanwhile the Rome is burning and you have to enroll. Extremely complicated venture that really was more of an administrative task than a research task. But yes, very complicated.
Hi, my question for Dr. Farber is based on your primary endpoint. I saw that you are looking at amputation-free survival and overall survival, which were the main endpoints in the basal trial as well. But then your primary endpoint is a little bit different, and I was hoping if you could explain just the rationale or reasoning behind that.
Yeah, so endpoints are, primary endpoints are extremely important in the trial, because typically a randomized trial is powered for such an endpoint. And so it's very important to choose the right endpoint. And it's extremely complicated in CLI because there's so many considerations. The endpoints, for instance, that are used by industry in trying to get a device through the FDA have their own reason, and they may not be clinically as relevant as we might think. And the endpoint that was really sort of the most common endpoint used in trials of this nature was amputation-free survival. That's what basal used. And amputation-free survival, the problem with it is that, first of all, it had a significant focus on death, and it ignores the fact that death and amputation are not the only factors that are relevant. Actually, you could argue that reinterventions are also important. And then the question is, well, do you include all reinterventions? And if you include all reinterventions, you might have a situation where, let's say you include angioplasties. Well, some people might say, listen, if we do an endovascular intervention, and maybe the patency is less, but of the intervention, but then maybe every year you have to go back and do an angioplasty where the patient comes in for the morning and then leaves. Is that really a big deal? That's the whole advantage of the endovascular approach. So you can't really penalize that, right? And so in the end, we had to sort of think about that and chose an endpoint called major adverse event free survival. This was an endpoint that was designed by a objective performance guidelines group that met about 4 years earlier to decide on better endpoints that should be used in evaluating devices on the endovascular end. And so we had a manuscript that was written. It wasn't published yet, but one of our I guess I would say advisors, who eventually was on our executive committee, was a primary author. He shared it with us. And we sort of said, you know what, I think this endpoint makes sense. And the endpoint includes death, it includes amputation, but it also includes major interventions, meaning a new bypass or thrombolysis or a jump graft. So these are relatively big procedures, and excludes angioplasty, stenting, because we thought those procedures maybe they're not as they may be okay to tolerate those procedures if for the patient. You see what I mean? So we chose that, and then we had a big summit where we brought together sort of leaders in radiology, vascular surgery, cardiology, vascular medicine together. We chose people to be sort of a part of our steering committee, and they all agreed that this was a good endpoint. But we pitched that to the NIH, and they have never seen that endpoint. So we had to convince them that this is a better endpoint than amputation-free survival, and they bought it, and they allowed us to use the endpoint. So that's the background. But endpoints are very important, particularly primary ones, because the trial is powered for them.
Farber, thank you so much for coming. I have a question that's related to Austin's question about endpoints. One of the endpoints that you're measuring is the economic impact of this study. And I was just wondering, can you comment on that? What was your motivation to assess that outcome? And what do you predict the effects will be on hospitals in terms of administration or possibly insurance companies? I just want to hear your thoughts on the economic impact.
Yeah, I mean, it's a great question. I mean, the question, when you're talking about choice of strategy, it all depends on your perspective. And, if you adopt a perspective from society perspective, then you have to think beyond clinical outcomes. So clinical outcomes are important. Quality of life is important, but so is cost, right? We have a runaway cost situation in the United States where I think it's these days it's 18% of GDP spent on healthcare. And we know that outcomes in this country are not as good as in some other countries which spend less. So cost is a big thing. It's a big deal. And I know that, many physicians don't like to talk about that, and they don't want to they want to discount it. But the reality is, if you think about this perspective from sort of to society, what is best for society, you kind of have to incorporate costs. And so in doing this trial, it was obvious to us that we have to incorporate costs to sort of help guide adoption of whatever findings we find. Right, we're going to know the results from the BEST trial this spring because the trial is closing follow-up right now. So we need to help people understand how to best use these data. And so cost is important, and that, because that's value, right? Outcomes over cost is value. What is the value of this choice or that choice? And so we knew that it was critical, and when we pitched the idea to the NIH, they confirmed that was important. And we also met with CMS on several occasions. It's very important to them. And so it turns out there are very few people in the country who specialize in this, in cost. And we found Dr. Nitish Chowdhury, who is a professor of medicine at the Harvard Medical School, Brigham and Women's Hospital, who is a big expert in costs. And we engaged him, and he submitted a grant by sort of together with us for a cost effectiveness core. And so we are going to calculate costs, and I think it's going to be critically important to inform how to best use this therapy. Imagine a situation where there is no difference. Well, if there's no difference in clinical outcomes, what about the cost, right? If there's no difference in one treatment therapy strategy costs twice as much as the other, that may drive decisions about how to best use it.
I had a question about how did you try to recruit a diverse population, including underserved or underrepresented minorities, and for example, like female patients for this trial? I know that this is particularly an issue, for example, at like BMC, where we do see a lot of these patients.
Yeah, great question. So it turns out that when you submit an application of this nature to the NIH, they actually want you to tell them what percentage of your trial is going to be represented by underrepresented minorities, and so we've done quite well. Our percentage of non-white race minorities, for instance, is higher than predicted. Interestingly, our percentage of women is a little bit less than predicted, and that's because for some reason there's evidence to support this. It's much harder to randomize women, and we've been struggling with that. We've been working. Our DSMB has talked about that for the first 2 or 3 years of our Data Safety Monitoring Board. That's what the DSMB stands for. That's the group that oversees the trial, who knows the results already. There's a firewall between us and them, but we meet twice a year, and that was a big topic of how do we get more women into the trial. The reality is that CLI is a disease that affects vulnerable populations, and not surprisingly, the top 2 enrollers into the trial is USC and Boston Medical Center, and both of those are safety net hospitals. And so, I think that, in fact, the outcomes of the trial is going to help such populations. But we've been trying. We actively try to do that, and we did that by choosing sites appropriately. I guess that's a big driver of that.
Dr. Farber, I was wondering if you could kind of explain to us why you guys elected to go with a superiority study design as opposed to like a non-inferiority.
So when we were deciding which design to adopt, we met with this was about at the time that we connected to our data coordinating center, and their statisticians and us sat together and we started to think how to do this. We did a power analysis to tell us how many patients you need. And it turns out that for a non-inferiority design, the numbers were much higher. It was like somewhere in the range of 6,000-7,000 patients. Ironically, it wasn't. It didn't make sense to me because I would have thought the opposite. But in fact, the numbers were higher. And so that was the reason why we chose that strategy. We listened to our statisticians and we looked at the numbers, and superiority makes sense. Certainly inferiority might have made sense as well, non-inferiority. But we were driven by the end.
Another question that I had for you was in terms of recruiting the physician cohort. Did you find any sort of, pushback between specialty or between disciplines, or was there a cohesive goal between everyone wanting to find the answer to this question?
No, there was a lot of that. So let me just be completely transparent. When we organized the trial, it was basically the idea was, it was sort of mine and Matt Menard, and we sort of had, and we both vascular surgeons, and our idea was, and we were very, we had no experience in running trials. We were sort of naive in many ways, and we kind of thought, vascular surgeons do both. And so it makes sense that you include vascular surgeons because they can, most modern vascular surgeons do both. And when we pitched this to the NIH, they said, "Are you nuts? Absolutely not. You have to go back and include everybody," which was completely the right thing to do. It just shows to you how inexperienced we were. And so we went back and we brought in Kenny Rosenfield, who's an interventional cardiologist, and we created an executive committee that included representation. So, Michael Dake, you probably know, John Kaufman, those individuals who are really leaders in the field of radiology, and, from cardiology and vascular surgery as well, got everybody together. And in fact, the way the trial was organized was a very careful negotiation because, as you can imagine, you take some of these individuals would spar at meetings. There was a lot of tension, even in our small executive committee between the cardiologists and the vascular surgeons and all that stuff. So we brought everybody together. And so we did that at the level of our trial. And in the end, in fact, if we talk more about the design of the trial, you need to understand that it was designed in a way to ensure that everyone's agenda was completely parallel. We had to make some concessions from the way the trial was originally designed to satisfy, appropriately so, but to satisfy other people's opinions that relate to sort of a specialty-wide view of the universe of CLI and its treatment. So that's number one. Now, in terms of the sites, yes, it was very difficult because many of you don't remember or don't know because you're younger, but there was a lot of strife in the early 2000s between specialties, and there is still strife. It's less so right now, I think. I think in most places people have gotten to some equilibrium that is reasonable, but not every place. But there's a lot of strife in terms of who should be doing these procedures, and there was a lot of reason for the strife. And so, as you can imagine, when we were choosing sites, first of all, we wanted to make sure that we didn't just want vascular surgeons, we wanted cardiologists and radiologists to participate. And at some sites, we wanted them to lead the site because the NIH does not allow, so they allowed us to have 3 specialty PIs, but they said that one PI has to be the contact PI. And so we had to choose one. So you imagine a site where there's a lot of competition between the specialties, a lot of rancor. How do you choose one or the other? Very complicated political decision-making. But yes, it was complicated. And it was interesting because we lived it with all the sites. With all these sites, I've learned an enormous amount about the sites at which the care is delivered to these patients across the world, to be honest with you, not just the United States. And I can tell you name me one of our sites and I can tell you what the dynamics are. And there's some sites where everybody gets along. There's some sites where, only vascular surgeons are doing this. And there are some sites where actually radiology is who's driving the ship. And some sites cardiology. And so we had to be sensitive of that. And you can imagine, I remember there was one site, I'm not going to mention the site, but we chose an interventional cardiologist to be the contact PI. I got an email from the president of the Society of Vascular Surgery, basically chewing me out as to why is it that I chose this individual at this site instead of the vascular surgeon, right? I mean, it was stuff like that, crazy stuff. But yes, it was an interesting experience. I think in the end, I think this whole trial has allowed people to get closer and work better together, to be honest with you. That's my sense. But it was difficult.
So I just kind of want to ask a quick follow-up to that. What, broadly speaking, what kind of lessons have you learned and will you use moving forward to help bring people from different specialties and who might have slightly different agendas together to work together to kind of form a cohesive unit for what's best for the patient?
Yeah, I mean, that's a great question. And this really transcends the trial. I mean, this part of the trial is not really about research, right? It's really about administration. That's why I said it's more of an administrative task and less administrative lessons in leadership, really. I a few years ago went back I got my MBA, executive MBA. And in my MBA classes, I've learned a lot of the things that I learned in this trial. So this is sort of a common thing. So the question is, how do you get people together? Well, you have to, first of all, appreciate that people have different agendas. You have to have emotional intelligence to understand where people are coming from. And you have to create an environment where you get buy-in from everybody. And you have to, and that includes negotiation, and that includes sort of appropriate relationship building, and that includes listening, and it varies from site to site. And this happened almost at every site. There are very few sites where it was pretty straightforward. How do you engage people? Think about this. We were able to convince an interventional cardiologist to join our team, right? This was at a time when there was a lot of infighting between interventional cardiology and vascular surgery, right? It was sort of people were screaming at each other at meetings and saying nasty things about each other. But we did it. because you have to create a joint agenda, an agenda that's acceptable to all, and you have to listen to people, and you have to compromise. And so the trial, for instance, the design of the trial, we can get more into this if you ask questions about that, is in fact a compromise where we listen to the non-surgeons, because they had significant issues with the way the trial was designed. They were worried that the trial was designed comparing best open versus all endo, right? And then the question was, well, let's do it differently, but there's no, how do you know what's best endo? We don't know that, right? So it's a lot of work to do that.
Dr. Farber, I myself, and I think everyone here would love to hear more about the compromises you were talking about.
Yeah. So again, the idea is, so when you think about surgery, bypass surgery, a big factor that the advantage of bypass surgery theoretically is durability, right? There's obviously greater complications around the time of the procedure, but the question is it more durable in endo, in CLI? And so we sort of thought, well, let's take the best of surgery, because when you do bypass with great saphenous vein, single segment great saphenous vein, that's using best possible conduit for the bypass versus prosthetic. Prosthetic bypasses don't stay open very long, but vein bypasses do. And so we kind of wanted to compare single segment saphenous vein, best possible conduit from bypass, to endo. Because our thought was, a lot of the surgeons now are choosing endo. It's not even the non-surgeons. A lot of surgeons right now are choosing not to operate into endo. And so our thought was, well, let's just compare all of endo versus bypass with single segment, adequate single segment saphenous vein. And to us, we kind of had a blind spot. It made sense to us. But then when we talked to the radiologists and the cardiologists, they kind of said, well, wait a minute, that's not really fair. Because basically, because they have a different perspective. And they said, listen, you're basically comparing best open versus all endo. And you're disadvantaging endo. And so then we said, well, okay, let's compare best open. Let's compare best open versus best endo. The problem is you don't know what best endo is. No one knows that. Is it using stents in the SFA? Is it using a thorectomy? Is it debulking first and then stenting or stent grafting? No one knows, right? And keep in mind, there's tremendous heterogeneity in the anatomy in the lower extremity in CLI. So no one knows. So that's not possible. And so we compromised by having two cohorts. Cohort 1, which is basically best bypass versus endo, and cohort 2, which is not best bypass. So in cohort 2, it's a smaller cohort, but cohort 2, it's bypass using prosthetic, using arm vein, and that sort of thing, versus endo. So we have two comparisons, and we have agreed not to mix them together. They're separate. They're going to be analyzed separately. And the assumption is, every time you run a trial, you have to have a hypothesis, because that's what you base your power on. So the hypothesis is, now I don't know whether the hypothesis is true or not, because we'll find that out in a few months, but the hypothesis is that bypass with good vein will outperform endo. And endo will outperform bypass with not good vein. Those are our hypotheses that we organize a trial around, right? Whether it's true or not, we don't know.
Dr. Farber, we were looking in your paper and it says that you utilized international sites, I think in Ireland, in Italy, and we wanted to know if an international component affected the study in any way, or what your thoughts are on that.
Well, this is an interesting story. There's a reason why we did that. We had a tough time driving enrollment. Enrollment was very difficult in this trial because this is not a trial that's testing some new sexy stent or device. It is a trial that's testing strategy, and it's forcing people to be uncomfortable. Every time a physician makes a decision to randomize a patient, they usually have an idea of what's best for that patient, right? Whether it's endo or open, it varies. It may be two people may think differently, but they have an idea what they would do without the trial. We're asking them to suspend that bias and just enroll the patient. So they're already uncomfortable. And so enrollment into BEST was very difficult, very difficult. We traveled, I must have visited, I don't know, like 80 sites. I used to travel twice a month. I'd be traveling to another site. And the whole point of traveling is to give them talks and push them to enroll and find out what the obstacles are. And I have talks about obstacles and trial and all that stuff. So at some point it became obvious that we just were not enrolling fast enough and we needed more sites. And so we said, okay, well, we talked, our DSMB said, you know what, go outside the United States. And so we went to Canada, but there's just not enough sites in Canada. And so we decided to look elsewhere. But the question is, where do you look? And we did our homework, and we found out that there's actually not all countries have equipoise. So for instance, Australia, there is no equipoise. It's all endo. So no one would enroll in Australia. In Finland, we knew that there was a group in Finland of vascular surgeons, a very big group that does a lot of research in CLI. And so we approached them, and in fact, they do both evenly. That was a great choice, a great group of physicians. And then we looked around, and there were other countries that, for instance, we didn't want to go into Russia because there were some issues about potential, problem with data points. And so in the end we ended up, and then Basel 2 was going. So Andrew Bradbury is in parallel running Basel 2. So he is in United Kingdom and Sweden and Denmark. So we can't really go there. So, and then France. So we approached France, and the process in France to get IRB approval is ridiculously long because we didn't have a lot of time. So this was an international sort of global tour about where we should do this. And we wanted in Singapore, nobody does bypass in Singapore. So obviously you can't have that, in Poland, they told us that they do both, but we weren't sure that we kind of wanted people where we knew that they were like really doing the same kind of procedures that we're doing in North America. So it was a very tough process. It turns out New Zealand, there's equipoise. In New Zealand, so we had 3 sites in New Zealand that actually helped us, and because they do both. So it was an interesting sort of trip through CLI equipoise across the globe to figure out what sites, what countries would actually, be a good fit for BEST. And so that's why we ended up in. And I wish we had more time. We probably would have gotten more sites in Italy if we had more time. There were a couple of people that we could not bring on just because we were running out of time ourselves.
Hey, Dr. Farber. I just had a quick question for you. So thank you again for sharing your expertise and wisdom with all of us this evening. I had a question about the pragmatic nature of the trial and also about like the flexibility you had with allowing a variety of endovascular procedures for vascularization. How did you go about accommodating for the rapidly growing field of PAD vascularization therapy and the new procedures and technologies that were coming up while this trial was going on?
Yeah, so great question. As I've intimated before, Basel used angioplasty alone, which makes it completely obsolete. It was obsolete before it finished. And the reason for that is that in the United Kingdom, that's okay because they don't place a lot of stents, but nowhere else, most people don't use angioplasty alone. And so we realized early on that how do you standardize this? How do you standardize, how do you even do that? I mean, right now, some people use a thoracotomy, some people use stents, some people use drug-eluting balloons. And we realized that we kind of wanted to avoid the issue of immediately being obsolete. And so how do we do that? Well, we first of all make it a pragmatic trial, which is a real-world trial, where you allow the physician to make their own decision of what they want to use for the strategy. So in other words, if a patient gets randomized to surgery, the surgeon can use a reversed vein bypass. They could use an in situ vein bypass. we'll leave it up to them because we want them to do what they would do in their clinical practice. So the theory being, as long as you choose good surgeons, you'll get good outcomes that will reflect real world. Same thing for endo. Endovascular specialists, if somebody has uses a atherectomy and that's what they use and they have great results, they should be allowed to use that. Obviously, that presents a problem. So on one hand, it allows for you to be pragmatic in real world, but it creates a lot of heterogeneity, and we're going to be criticized for that. The problem is there's no way to win here. What we did is we had an evolving technology committee that Dr. Kaufman chaired, and that evolving technology committee was consisting of experts who basically said, if there was a new device that was coming to the market, for instance, drug-eluting stents, drug-eluting balloons, that as the agreement is that we would allow something, that committee would allow something to be used in BEST as long as it was standard of care in the United States. So when the BEST started, drug-coated balloons were not standard of care here, but then they became available and they became standard of care, and the committee evaluated the balloons and voted to allow use of these balloons. And so that's sort of how it happened. So, and the committee met on a number of occasions to look at stents and some other things as well. So that's sort of how we did it. Is it perfect? No. Are we going to be criticized for it? Yes. In the ideal world, if you could enroll 50,000 patients with CLI, then you could have 40 different trials and randomize 1-to-1 and diminish heterogeneity to almost zero. But it's not feasible to do that. This was a better choice than choosing stents, because then you have what about stent grafts? So that's how we did it. It was a difficult sort of journey for us, but I think that we landed in the right place, although we are going to be criticized for that. Now, here's a question from the audience. What criteria were used to decide that a site has good endo outcomes? Great question. So one of the criticisms was, I'm sure will be, is that you have a lot of surgeons among your PIs, and are they really as good as interventional cardiologists or radiologists in endo? And so, good question. And this is something that we've wrestled with for many years. The reality is, and there are three answers to that. One is you have to have, you can have surgeons who are not very good at bypass either. I mean, how do we know if the surgeons are doing good bypass and have good outcomes? We don't know that. So that's number one. Number two, we have a credentialing committee that had certain credentialing minimums that a surgeon had to be credentialed as a surgical investigator, and an endovascular specialist had to be credentialed as an endovascular investigator. In other words, they have to have done 15 tibial interventions to be credentialed as an investigator. And this is a very difficult thing, because where do you draw the line, right? And the reality is, we are going to be criticized. I mean, there's some people who, on the circuit who are going to say, these people were not as good. But this is a real world trial. It's a real world trial. You can't have a trial that's only, procedures only performed by people who are, in the stratosphere and talk about it. Then so it's a real world trial. And we did go back and look at, the credential committee actually reviewed some op notes as well, from these procedures to see whether they thought things were done reasonably. Again, is it optimal? Perfect? No, it's not. Ideally, there would have been a core lab that reviewed every case. But again, now you're talking about $100 million, $150 million trial, which will never be done.
I was hoping you could maybe talk to, when you get a grant such as this, just kind of generally, how is that structured? How does that money kind of get distributed? If you could just kind of speak to that a little bit.
Yeah, absolutely, David. So basically, if you apply for a grant for the NIH that's greater than $500,000 per year direct, there's a special process where you have to basically pitch your idea to a group at the NIH, and you have to have a price tag to the idea. And if they like it, they give you a green light to submit the R1 grant. And but the price tag stays. And so we actually went to pitch this to the NHLBI. They gave us a green light. We submitted the R1, and then we were told that one of the criticisms was we were initially rejected. And we had a very high score. The lower the score, the better. We had a high score, and the criticism was you're not asking for enough money. You need to pay sites more money. So we have to actually go back through this whole process again. And the way so once we did it the second time, the money, you can't ask for more money. And again, in retrospect, this is a pittance for what this trial of this magnitude actually costs. It costs 3 times as much to do if you did it sort of in industry. And then, for us, there were actually 3 applications: one for the cost effectiveness core, one for the clinical coordinating center, which is sort of the 3 of us, 3 PIs, and then one for the data coordinating center. If you run a trial like this, you need a data coordinating center. And this is a center that runs the trial. They're the center, that's the center that ensures that all the sites do what they need to do, and they follow up and make sure that all the queries are answered and that sort of thing. And so they also received, their piece was much bigger than ours because it included site payments. And so yeah, and then you get the money, and the money has to come to one institution. So even though there are 3 PIs, we agreed that the contact institution would be the Brigham and Women's Hospital. We agree, and there was a couple of reasons for that. We agreed, and so Mass General, where Kenny is, and BMC, where I am, were subcontractors from the Brigham. So the money went to the Brigham, and from the Brigham, it came to Boston Medical Center in my instance, for example. And it's a big deal. I mean, there's all these rules around how money is spent and so forth. And in fact, in the end, we didn't have enough money to finish the trial. We needed $7 more million, and we went to the NIH and we said, listen, we need this money. And they said, okay, why don't you apply for it? We applied for it, and they said, sorry, we don't have it. And so we ended up raising $5.5 million ourselves and we approached physician organizations, we approached most societies, including the Society for Interventional Radiology, who has been very supportive of BEST, has given us money. We actually went to industry. Initially, we didn't want industry involved at all, but we had to, and we went to industry and we said, can you help us? And a number of companies gave us money to sort of get to so that we could finish the trial and have enough follow-up so that the projected power to answer our question is 90%.
Dr. Farber, I have one final question for you. Do you have any last thoughts or advice for trainees interested in pursuing level 1 research?
Yes. And the advice I have: be bold, think big. We never thought, if somebody told me in 2008, or 2007, the day after we had that beer and had this conversation, that I was going to be running an NIH-sponsored trial, that would be the equivalent if somebody told me today that tomorrow I'm going to take a trip to Mars and spend a few days there. It was completely out of scope, I never thought it would happen, ever. It was like a dream, a daydream. And the point is, it did happen. And so what I've learned from that experience, and I think this is relevant for trainees, is think big, believe in yourself, and don't be afraid to try it. Don't be afraid, even when the odds seem like they're impossible, even if the odds seem ridiculous, even if people, they said they basically called us, moderately published surgeons. That was sort of like, nobody thought, but we surrounded ourselves with people who knew We created an environment that obviously gave the NIH enough sense to give us the money. And it's so you got to believe in yourself. You have to think big. Don't be afraid to try something new, because it can happen. If it happened to us, it can happen to any one of you. The idea has to be good, and you can't give up. Think big. I guess that's my message.
Thank you so much for all your insights on the BEST-CLI trial, Dr. Farber. It's been so enlightening to hear about all the challenges and decisions you made during the design and execution of your trial. I think all vascular and interventional trainees can really learn from this. So thank you so much for your time, and thank you so much for coming, everyone.
Thank you. Greatly appreciate it. Thank you for the invitation.